Hello.
Hello. Hi.
Hi, Leon.
How are you?
Good. Where are you coming from?
Just outside of Chicago.
I see. What's your background?
Physical medicine rehab, and I'm also part of a physician startup doing it in extended reality group,
I see.
and that use legal background as well.
Oh, good. So I'm with the Society of Physician Entrepreneurs.
Yes, I am, as far as I remember, still a member. I
Oh,
joined
good.
some time ago.
Good. How's your startup coming?
We're actually doing okay. We have a contract with the VA, and we're just part of a team that answered a request for a proposal for a larger VA contract. So we're just
It's a tough gig dealing with the VA.
yeah. Once you get past the paperwork, then you're halfway there. Right?
Yeah. All right. Exactly. I used to work for the VA a while.
Yeah, I'm a veteran, so I understand.
I see.
From the other side as well.
Yeah.
I do have just a general question about. Obviously, startups need. So I'm also a licensed attorney, so part of my interest in this is working with startups and trying to get advice and offer legal assistance. So, just from your experience, what do you view as the need? I know there's a need, but as far as is the need being met? I guess.
There are three. One is choosing the right corporate entity and organizational governance. So for all intents and purposes, a startup attorney. Two is intellectual property. Three is rules and regulations concerning raising private money. And my experience is that no one attorney can do all three. It's like going to a neurosurgeon and expecting them to do something, everything. It just doesn't work. So those are the main issues. And then the problem, I believe, has to do with mindset and money from the standpoint of the attorney. The attorneys that I have dealt with and deal with are not entrepreneurial attorneys, unless they're startup attorneys. They have somewhat of a different approach, but they don't have they play defense all the time. You know how lawyers are.
Yeah.
So that's not consistent with when you're trying to kind of push the envelope. And the second is, I don't need to tell you, startups don't have money to pay you what you think you deserve, and probably do. So then the question becomes, how do you pay for the services? And where does that lead? And do you really want to get involved with it? Because what the startups are going to tell you, at least what my view is that, they'll say, well, do you have like an associate in the office that can file a trademark for, $100 or whatever? So they don't have the money to pay you what you deserve. Now, when you get further along, in terms of scaling up, then that's a different story, because now you have to deal with HR issues, you have to deal with contracts, you have to deal with operations, you have to deal with a whole bunch of stuff that you didn't have to deal with when you were a startup.
Right.
And
so
then, of course, as you grow, if now you're looking for public money, if you're going to do a public exit, I don't care what it is, then you obviously need somebody that knows what the heck they're talking about in the specific domain, whether it's a non-exclusive licensing agreement or whatever it is that you need to have done. That as you get bigger and bigger and the stakes get higher and higher, you need more and more expertise.
So the better route is to look for companies that are somewhat down the line, it sounds like.
Well, from an attorney perspective,
right.
Yes. I mean, unless, I mean, I participate in companies all the time, and I'm not a saint. I would like to be paid for my services, but I also do this as part of a social mission to an extent. So it's really just up to the individual, is there a possibility of future engagement? Is this something that's has wheels? Is it something that may lead to something bigger? Who's on the, who are the people that you're dealing with? Do they have connections that may result in a paid gig? That kind of thing. So it's not totally tangible benefits, immediate tangible benefits. And by that, I mean money. There's actually a lot of intangible benefits getting involved early, but you have to sort of decide, is the juice worth the squeeze given your present state?
Right. Okay, I appreciate that. Thanks.
Sure. Hi, Leo. Leo, are you on with us? Guess not. Yeah, and actually we just had a SoPE, I don't know whether you saw it, but we had a SoPE webinar on licensing agreements in biotech, and it's actually on the SoPE YouTube channel if you want to view it. Leo, can you hear me? Hi, Jessica.
Good morning.
How are you doing?
I'm well. How are you?
Good. Thanks for joining us.
Yeah, absolutely. Thank you for having me.
Yeah, so we can discuss offline what you want to do with the DTX and our involvement, but I told you I'm involved with that group, so if you want to do stuff, we can talk about it offline.
Yeah, wonderful. That sounds great.
Yeah. And it would be good for you to, it might be worthwhile for you at the appropriate time maybe to chime in, because this subject really generally has to do with basically how do you pick a digital health vendor. It happens to be an AI, but whether it's a digital therapeutics vendor or any other kind of digital health vendor, how do you do that?
Yeah. Yeah, I'm happy to talk about all of that.
Good. And you might want to put your LinkedIn profile or your email if you want people to contact you in the chat.
Yeah, sure.
Hi, Usman.
Hi, Dr. Myers. Good morning.
Morning. How you doing?
Doing good.
Good.
How about you?
Yeah, good. Stuff's moving along.
Yeah.
And how about you? Where are you in your journey?
So yeah, I'm motoring along right now. Starting my second year of PhD, so trying to stick to the PhD.
Oh, you decided to stick to the PhD?
Yeah, things are working out fine. So plus I will try to finish it as soon as possible in record 3 years time. So
Yeah, good.
yeah. So let's see.
Good. So is Kasia around, or do you know whether she's
She sent me the email yesterday, but other than that, I'm not sure.
Okay.
Uh,
I
if
thought I
she-
had her. I thought I had her linked her phone number so we could text her. But
Oh, okay. Yeah, let me see if I have her cell number as well.
What?
hi, Ben.
Hi, good morning, everybody.
How are you?
Good, it's Ben from New York City. Nice to meet you.
Hi. Good to see you again. Hello, Michael.
Oh, good morning.
Dr.
Morning.
Strong, good to see you again.
You too.
So, Michael, you're one of the speakers now.
Yes,
Good. Thanks for joining us.
sure. Thanks for the invite.
Sure. Yeah, we're waiting for Kasia and the rest of the crew to join us. Hi, Anthony.
Hey, good morning.
Welcome back.
Thank you.
Michael, do you know Anthony?
No,
So Anthony is a colleague. He is at Children's Hospital of Orange County. Anthony, you want to say hi to Michael? He's one of the panelists.
Hey, Michael, how are you?
good morning. How are you? Nice to meet you.
Likewise.
And Michael, I forgot what your role or your position is.
I'm the CMIO here at the U of U.
Good. Hi, Kasia.
Good morning, everyone.
How are you doing?
I'm doing great. How are you?
Good. Thanks for putting all this together.
No, it's a pleasure. And important topic, I guess.
Yeah. And Kasia, do you know Anthony Chang?
I think we saw each other at the Artificial Intelligence in Medicine conference,
Right.
Right.
but we didn't get a chance to speak.
Yeah.
I just was in the listening mode.
Yeah. Kasia runs the Nevada SoPE chapter. Amongst his many hats, Anthony runs our Orange County SoPE chapter. Hi, Joel.
Hi, just had to unmute. How are you?
Good. How have you been?
Good.
Good. Are you in Copper or in?
Yep.
Oh, cool. Good. How long are you going to be there?
Oh, just a couple of days, then heading back to Kansas.
Nice. Good. Morning, Donna.
Hi, Usman. Hi, Rudy. Nice to see you.
Hey, Kasia, nice to see you as well.
So Kasia, at 8 o'clock, I'll turn it over to you.
Yep. Let's just start.
Go ahead.
I think
Thanks.
we have quite a busy agenda for today, and I'd like to welcome everyone. It's the webinar, how to choose artificial intelligence vendor for your healthcare organization. We organized it between the Utah, Nevada, and Colorado chapter of the Society of Physician Entrepreneurs. And maybe because I see there are some attendees on the call who are not members of the society, let me just give you a very short overview of the organization. So it's a global nonprofit organization. Was founded in 2011 by 3 physicians, I think including Dr. Mayers, who's on the call. And the common vision is to really support physicians and other health professionals to innovate through entrepreneurship. And the organization is growing. It currently has multiple members, both healthcare professionals, but also organizations and investors. So if you are not a member and you are interested, please join us because a lot of things are happening in the organization. And this webinar in particular is responding to an increasing interest in healthcare innovations based on artificial intelligence. And we know that the adoption of artificial intelligence in medicine is a little lower maybe than in some other sectors. And there are many reasons for it. But one of the reasons is some difficulties in adopting artificial intelligence solutions in our healthcare system. So today we invited the panel of experts to discuss the reasons for it and maybe some solutions. So the experts represent the healthcare sector and also Digital Therapeutics Alliance. And we will discuss the criteria for choosing an artificial intelligence vendor. So I'd like to introduce the panel of experts. And maybe let's start with Donna and tell us please who you are and what is your role.
Sure. Good morning, everyone. I'm Donna Roach. I am the Chief Information Officer for the University of Utah Health here in Salt Lake City. And I have been in healthcare IT for close to coming up on 40 years. I've been a Chief Information Officer for about 15 years. I started I'll go backwards a little bit. I came from St. Louis, where I was with BJC and WashU, and prior to that, I was with Ascension for 7 years in various markets: Michigan, New York, Kansas, Gulf Coast, and then the system office. So I have a background in health administration with a focus on systems, and absolutely love the combination of healthcare and IT. So thanks for having me.
With us. Thank you for being with us, Donna.
Yep.
Mike?
Good morning, everyone. My name is Mike Strong. I'm the Chief Medical Information Officer here at the University of Utah. I have the pleasure of working closely with Donna. I'm a practicing internist, hospitalist is my clinical role here, but I've been I've been the CMIO since approximately 2008. I did take a few years off to do some volunteer work, but have really been in this role since about 2008. And like Donna, just enjoy the challenge of trying to blend IT solutions with healthcare and to lead to better outcomes for our patients. Thank you for having me.
Thank you, Mike, for joining. It's our pleasure. And Jessica?
Good morning. Thank you. Also, I'll echo that. Thank you for having me today. It's always an interesting conversation. I'm really excited to have this call with Dr. Strong and Donna and you all. So I'm Jessica Hoffler, Chief Operating Officer at Digital Therapeutics Alliance. I started my career in social services, working to improve patient access to healthcare in all shapes and forms. I've really kept that to heart as things have evolved over time. My role before this was working for Cambia Health Solutions in their external innovation arm of the company. And we worked a lot to identify enablers of innovation. So we talked a lot about infrastructure like data interoperability, incentives for healthcare, and And then the culture of healthcare. So I know you touched on, talking about the barriers to adopting AI or other solutions. And, maybe it's the optimist in me. I have to keep it in healthcare, but I like to talk about them as enablers and opportunities.
Thank you, Jessica, and thank you for reminding us that every issue is in fact an opportunity, because that's very true. So let me get started the discussion by saying that typically health innovations, all types of health innovations, not only digital or based on artificial intelligence, are usually assessed based on 4 main criteria. One is clinical, another one is economic, there is technical aspect, and then there is patient-related aspects. So I'd like to find out if artificial intelligence solutions are assessed based on the same criteria, or if you take into consideration something else. And maybe we'll start with the healthcare system perspective. So Mike, I'd like to ask you first if you could tell us a little bit more about these or other criteria that you consider.
Okay, thank you. I think that those criteria are good criteria and form a foundation for, making any kind of an assessment of an application or that you might be wanting to introduce into your environment. One of the interesting things about that I would call out specifically would really be the usability of it and how well it integrates into the workflow. One of the things that I at least see or hear about so frequently from my colleagues is, well, that's a really nice application, but it means that I have to leave my workflow. I have to do something different. And there's ever an increasing amount of pressure on providers. When I say providers, meaning physicians, really nurses, social workers, anyone who's delivering care to a patient. There's so much time pressure on all of the providers that asking them to jump between multiple different applications is often met with resistance. And so one of the criteria that I at least think needs to be evaluated is how well is this going to integrate into the workflow that's already established. That doesn't mean that we can't work on new workflows and develop new workflows, because I think that especially with AI, that's actually going to be something that will need to be done. AI is in many ways disruptive, and so doing things in a different way and thinking about doing things in a different way is progressive and good, but that needs to be balanced with established workflows, and trying to make wholesale changes very, very quickly will be difficult. So without getting too long-winded, I would just say that all of that workflow and that for adoption is going to be critical.
Thank you. So if I ask a follow-up question, how do you assess this usability of new applications?
Yeah, I think that with any application, so much of what we do will be in, we'll do pilots, we'll find different groups. In our, we have a large organization here, just as most healthcare organizations are. And, it's not just, one of the interesting nuances is that you can't just say, oh, this works well for, tested on 1 or 2 different physicians, just using that as an example, and then think that it's going to be adopted by everyone, because what all of you are well aware of is that, I'm an internist, so the way an internist looks at things is very, very different than the way a surgeon will look at things. And so we will, doing pilots, but being smart about the pilots and making sure that we look at different clinical groups and how that's going to be adopted. So that's probably the most common way that we would evaluate that.
And when you do a pilot, usually how many users do you include in a pilot? Just to be very specific about that. And how long does it usually take?
Well, it's a good question, but not an easy one to answer, is because I think it depends on the solution. You know, some things are, you know, some things have a what I would consider a small disruption or a small impact, and you may pilot it with just, you know, 2 or 3 different physicians or users in maybe 2 or 3 different specialty areas. If it's something that's going to be, you know, a big change in workflow, or is going to be where the, you know, if the consequences or the potential impact is estimated to be high, you may want to have, you know, 100 different users, you know, spread out across the organization, and the length of time is going to vary. You know, we've done some pilots where, you know, we may only test something for a couple of weeks. We have other pilots where we may go 6 months, just depending on the intensity of the application and how much it's going to change what we're currently doing. And you know, associated with that is also some risk assessment. You know, if it's a high risk application, meaning it's going versus a low risk application.
So can you tell us a little bit more about these issues with these pilots, proofs of concepts, risk assessments? What issues do you typically encounter?
Oh gosh, one of the things that we'll encounter is, you know, how well does it integrate into our current processes? You know, one of the challenges with any application, whether we're talking about an AI application or any other application, we'll talk to different companies, startups, and so forth, and they'll say, hey, here's this great application that we have that's gonna, you know, it's gonna, you know, be a game changer for you. And the problem is that I mean, it sounds good conceptually, but then the question that we'll always ask is, well, does it integrate with our EMR? And as soon as you talk about integration with the EMR, then so many times you hear, well, we're thinking about that, or we would like to do that. And whenever I hear those phrases, I get really, really nervous because I know that it may be a great solution, in the technology, the model that was used to develop the application. You know, if we're going to talk about AI, you know, and the output may be terrific, but if it's not well integrated into and doesn't play well with the EMR, then I know it's going to be a real uphill battle trying to get our users to adopt it. I came across an article recently that was where Gartner, this was about 4 or 5 years ago, but Gartner estimated that 60% of AI projects fail. And this isn't just in healthcare, this is, you know, across all industries. And then a year later, they revised that estimate and said it's somewhere in the 80 to 85% range. And the reason is there are multiple reasons, but many of those reasons that were cited are that just the lack of appreciation for usability. And so that's why I mentioned that.
Thank you. I think that's very important. And I'd like to turn it now to Donna to find out what is your perspective on this question.
So I always appreciate Mike's approach because he looks at it from a different lens in terms of how I approach it, but our lenses kind of overlap quite a bit. And he is smack in the middle of the usability crisis, I think sometimes we hit upon, because he is a hospitalist and he sees firsthand when he puts that hat on or when he puts that coat on, he sees the issues of usability. All good, efforts are out there, but when you put it in the hands of the actual practicing physician and the conditions of our patients, sometimes we have created disruptors and unnecessary disruptors. But 3 points, and Mike, you kind of touched on these a little bit. When we look at any, and you gave 4 kind of high level: clinical, economics, patient related, and technical. And there's a lot of probably subsets under each one of them.
Yeah.
But one thing I'll call out that I think becomes very important is the cultural fit. So any, with AI, with any like new application or new kind of workflow, culturally, it has to fit in your organization. And you would think it's like, okay, healthcare is healthcare. I've worked in several different organizations. This is an academic organization. I've worked in faith-based organizations. I've worked in very progressive community-based organization that, like we're the Malcolm Baldrige winners, right? Their culture is very different and will dictate how well an application is accepted or looked at. And I would definitely align that with AI. I think from a healthcare perspective, people are a little not even curious. I think they are skeptical. And so, and I think that there is a level of skepticism that you need to have. And, I think in an academic area research, it becomes very important when we look at AI. And so it's, we have several research groups here at the university that look at this and apply it and use our kind of data. We have a very I don't want to say funded, but we have a data warehouse that has been around for over 28 years. So it's populated with a lot of rich data, and that's a great learning ground for AI. So just kind of keep that in mind versus I pop myself out and I put myself now in a faith-based organization, the culture there is going to dictate something totally different. So you're going to have to see things and exercise things that are more around the ethical, I think, responsibility level. So in a Catholic organization where I came from Ascension, they're going to be very cautious about, okay, how do you apply, what was the learning model around AI in terms of maybe a clinical workflow? And they're going to dig a little bit more. Just because they're held accountable for some of the flows that are very different from what you might see in an academic environment. So kind of, I look at that, I keep that in mind. Another thing I would say is when we look at things, and Mike, you brought up the risk assessment, but I would also, I'm very much aware of the security, risk. And we have to be very cognizant of that and make sure that we are applying good risk frameworks to assess any tool that we use, and specifically in AI. However it's learned and however it's been developed, sometimes the creator of the AI doesn't always, and we've been in these situations, doesn't always have a security framework. And so we're like, okay, what's your security framework? How are you, incorporating those into your development, and especially if it's in the cloud, which a lot of AI tools we've looked at recently have been in the cloud. That brings on another level of security assessment that we need to do. And then I think I touched on this a little bit, but it's a whole responsibility ethics around specifically AI, but any kind of new innovative tool. One of, the past CMIO that was here before Mike Strong, she's actually gone and is looking at responsible AI in the area of race and ethnicity, because so many of the tools, right, and some of the workflow that has gone into clinical, assisting with clinical decision-making were based on maybe rules and data sets that didn't have the full race and ethnicity kind of background or information that we needed to have. And so how do you make it more responsible? And how do you look at those areas that right now we're smack in the middle of it? We learned this through our vaccination process and just our testing process. You know, how do we apply good ethical approaches when we're treating our community, which we know our community is quite diverse. But then when we look at the data, we see that, okay, how we applied it and, you know, and receiving the vaccine wasn't so diverse. So those are all things that kind of come into it. I think it complements what Mike was saying, but it takes, probably from my perspective, takes it down a little bit different IT path.
Thank you. Thank you, Donna. And I now would like to ask Jessica for her point of view. But before I do this, I'd like to point out that the Digital Therapeutics Alliance has just recently updated their value assessment and integration guide. And I think this is also in response to the growing number of artificial intelligence-based digital therapeutics that require some very specific approaches. So maybe, Jessica, you could tell us a little bit about that and how this value assessment and integration guide can actually help in bringing the right artificial intelligence solutions to the healthcare system.
Yeah, thanks for the plug. We did update our value assessment and integration guide this year, and it followed our first version that was then reviewed, and we were given feedback and input by around 300 clinicians and payers out there. So this incorporated a ton of good feedback. It's quite lengthy, about 50 pages or so. I'm happy to put a link into the chat, but it is first and foremost, it talks about the different types of digital health technologies out there. And I don't want to get off the topic of the guide, but I just wanted to add on to what was said before. I don't have a whole lot, except that I think it's really important that when decision makers, whoever you're representing, you're really looking at the problem and figuring out what problem are you actually trying to solve. It's the problem and the solution first before the technology. And that's something that we really double down on at DTA is what are you trying to solve first? What is the problem? And then you can start to find the right solution for you. So the guide really talks about everything from clinical impact and clinical evidence, everything from clinical trials to real world evidence and real world data, and what you do with that. Eventually that real world data sort of enables any AI capabilities down the road. But it also talks about or addresses data privacy, security, governance, which is more and more important these days. Patient and clinician engagement, that was already discussed. Workflow is huge. And then again, how patients actually use tools like digital therapeutics is another huge component, because the promise of digital solutions, digital health, particularly for patients, is that it's more engaging than a pill or an at-home therapy. And so the way that patients use it is extremely important. Again, integration, economic assessment, and quality metrics. How are we really following up and doing our due diligence on the quality assessment and analysis on an ongoing basis of technologies? And then you get into all those technical considerations, whether it's a static algorithm or AI machine learning. And Donna really dove down into some of the technicalities and considerations of that. Let me plug this in.
Thank you, Jessica. And I think, you know, you mentioned one thing that I believe is very important here. You basically said that you need to have the unmet need first and then find a solution for that. So maybe I'll turn it back to Mike and Donna and ask how this process works in your case. I mean, is the unmet need assessment the first step, and how do you prioritize these needs if it is the case? Or is it more driven by artificial intelligence vendors who come and present their solutions, and then you pick the ones that you believe can fit into the organization?
Donna, do you want to talk about like kind of our digital roadmap and this DEC strategy? That's kind of what's coming to my mind.
Yeah, I mean, you're kind of asking us to eat the whole enchilada all at once. But so when we look at things, you know, we've got an intake process, right? And the intake process is very much designed around, you know, if you think about it from our current organizational structure, but also our current application structure. So that's kind of like, okay, everybody has that, and every health system probably has some form of that, and they have a governance structure over it. What Mike is kind of referring to, and what we've gone down the pathway of, is elevating it up a little bit more to say, okay, we know that we're going through this digital transformation. And in this digital transformation, what's important to the organization? We've designed our digital transformation and our roadmap, and this is where I emphasize culture, is going back to our strategic plan. Our Dr. Good, who's the head of our School of Medicine and is the senior vice president for the health sciences, he has created kind of a 7-pillar structure, strategy document, and we do what we call directed steps every year. So that drives, and those are the inputs. That's another way of looking at the inputs to our roadmap and what goes on our roadmap. So that our roadmap from 2021 is a reflection of all of the strategy steps that have taken place in that strategy document, but also our value roadmap, which is more encompassing of the hospitals and clinics. So strategy document includes everything: health sciences, School of Medicine, hospitals and clinics, and our value roadmap is more about the hospitals. That is really the intake process, and what kind of shows up on our roadmap. Now, I will tell you, one of the things that is on our roadmap is innovation. So, and knowing that innovation takes place in several different layers of the organization. Here at the University of Utah Health, we have a group called the Pivot Center. The Pivot is kind of our big kind of more of an outward facing. It's like a kind of innovation. They do more commercialization. They protect the IP of the organization. They're kind of the big dollar amounts in terms of what comes in from an outside organization. That's another group that can have an influence on us in terms of what we look at. I would say that's kind of where a lot of the AI type vendors might be based. So we try to, we partner with the Pivot, but we also partner with other groups that also do innovation. We have a CMI group, which the CMI group is the Center for Medical Innovation and deals more with the wearables, like things that would be deployed and protected under the FDA. We also have a gamification, our GAP Lab. We have one of the largest gamification programs in the United States, and we do a lot of healthcare gamification. But even having and those are just the top 3, right? There's other little pockets of things that go on in the university. What we're creating is an enabling technology group that will allow us to input other kind of more, what I'm calling more innovative type solutions that we will want to look at and partner with. We had one recently come through in the security space, and they are applying AI around how to look at security, potential bad actors, and the characteristics of those bad actors, using AI and kind of influencing the kind of the characteristics, and then being able to apply some of that in our own organization. So that's kind of, I mean, it's complicated because there's so many inputs, but we try to capture it in various ways. I will tell you and Mike sits on these governance committees too. We have several organizational governance committees. One is our digital one is our application, Mike owns the data governance one. We have an infrastructure one, and we have a university one. And so all of those are kind of acting together to make sure, okay, what's on our roadmap and what are we doing? And is it all in alignment with the organization's kind of direction?
It sounds really impressive. I think you probably have one of the best organized process that I've come across. So very interesting indeed. I think Dr. Meyers is raising his hand. So Arlen, would you like to say or ask a question?
Yeah. First of all, thanks for your insights. I think the most common question that arises is, if you're a company, I mean, you've just described a really complicated, multi-level, time-consuming, lots of folks involved, long sales cycle. And everyone understands why you're doing what you're doing. But for a startup with limited funds, limited timeline, limited resources, they're trying to get their foot in the door. So what advice would you give? And my experience is, and maybe those of others, is every hospital, as Donna, you pointed out, is different. So you can't just say, well, we're going to do B2B. We're going to try to get our product into a hospital, because every hospital system is different. The culture is different. The process is different. The values are different, all the things that you've mentioned. So if you've seen one hospital, you've seen one hospital. And if you've seen one university hospital, you've seen one university hospital. So the key question is, how the heck do I get my foot in the door? If I'm a startup CEO, who do I contact? What do I do? Do I just go to the website and you have a care innovation input mechanism? Do I just fill out all the blanks and wait to hear from you folks? So what advice would you give to people who are just trying to get their foot in the door and maybe do a pilot, validate it, or maybe they're more advanced and just want to scale?
Well, let me take a stab at that. And Mike, you kind of, you can add in. I recognize that's a problem. And it's kind of, and I don't mean to be harsh about that. That's not my problem. Because realize I have 150, probably per week, of people coming to me with those things. So what I have to do and is look at what are the criteria by which I want to evaluate them. I will tell you, I think our Pivot Center does a great job because they are set up to do that. And I will say most larger healthcare systems, not all of them, but most will have some form of innovation, some track of taking in innovative ideas. And I think most of them have partnered with some kind of clinician in the organization. So I think that's a key criteria, right? I think the other thing that I have seen, and actually we're having some discussions right now, we'll have an organization called Matter. Stephen Collins is the CEO of Matter. He's coming out to Utah next week, and we're gonna talk to him a little bit more in depth about his program. He's based out of Chicago. Chicago helped fund the startup of Matter. I think Matter's been around for about 5 years. I think that's another opportunity for smaller startups to come in and get the credibility of your system, right, in that type of organizational structure. And there are others out there. The VC funding groups have various areas developed. So they have advisory boards to advise the startups in terms of what they're doing. There is HLTH, which is a group that has been formed, and Vive. I don't know if you anybody went to Vive this last year. That's another program that kind of helps in defining the startups, the healthcare startups, and gets exposure to the various groups and people that may have interest to them. So they're out there, and they do help in defining for that smaller startup how to get introduced and be in front of healthcare organizations. And that's a little bit of that helps me. And when I look at somebody to say, well, how are you coming about the introduction with me, right? That to me, that's important, because I don't have the time, nor do I have the money or the structure to totally evaluate me through my office. I have to rely on others a little bit, and actually heavily. And so that's why our partnership with the Pivot is really important to us, because they have an accelerator framework in which they look at things and apply kind of their knowledge and their experience in standing or kind of evaluating innovative groups. Mike, anything you want to add to that?
Yeah, no, I agree with everything Dawn is saying. And I guess Dr. Myers is asking a really good question. And it's a hard question because, as Donna pointed out, the number of, contacts by email or calls or whatever that I get is somewhat overwhelming. But I guess, but I want to address that question. And if I were a CEO of a startup, I guess I would recognize that every organization is going to have at least some degree of strategy, whether it's, as Donna described, kind of, it's a very deliberate, well thought out strategy that we have here. Other organizations are going to have lesser or greater rigidity around a strategy and deliberateness around a strategy. But all organizations are going to at least have some. And so I think doing the homework to figure out what is that strategy, and then asking yourself the question, how does my product align with the stated strategy of the organization? I mean, that I think you've got to be able to answer that question, and you've got to be able to contact the organization and say, we understand at least what you've put out there as your strategy. This is how we see that we can fit in. The second thing that I would say is, I think that the groups that I really appreciate working with are the ones that really do want to enter into a partnership. If it's just coming to me and saying, hey, we want to sell you something, sometimes that works, and sometimes we have a need to purchase something. But usually, if we're interested in purchasing something, we're out there looking, and we're the ones, kind of trying to find someone that's going to meet our needs rather than them coming to us. But if someone's interested in being a partner, one of the things that I've appreciated that Donna has really done is she's really trying to create very much a culture of agile methodology here. And so having a partnership with a startup where they're willing to come in, and where it's a true developmental, kind of partnership work, that's another way in. And then Donna mentioned something that I'll just kind of emphasize. So many, where did these ideas come from? I mean, Donna gets, she said 150 emails a week or whatever, and I get a lesser but still large number that come to me. I can't even think about all of those different requests. But getting a physician or a provider champion who is going to come forward and say, hey, this is an idea that we have. This is how I think it could grow in our area. Now, I'll be honest, if that individuals coming and they are so highly subspecialized that they're only treating, a very small segment of our population, not going to have as much, leverage in our organization as something. But for example, one group came to us and wanted to work with my associate CMIO on an AI-driven lung cancer screening. Well, we have the Huntsman Cancer Institute here that aligns with our strategy and what we're wanting to do. And that was a partnership relationship and developing an app that integrates through FHIR into our EMR. And so it kind of checks off a lot of those boxes where, hey, we're willing to be a partner. This is a large segment of population. This aligns with your strategy, and we can figure out a way to integrate it. And so, I mean, maybe that's too much, but I think if I were a CEO, I'd understand if I'm going to try and get into a space, that's the heavy lift that I've got to be able to do to be able to be usable and to generate some interest.
Thank you. And I think, Jessica, I'd like to turn it to you. You sit on a different side of the spectrum. We are very close to the startups themselves. What advice would you give them to increase their probability of success in healthcare organizations?
Yeah, thanks. So I agree, of course. I think knowing your customer is probably the most important thing. As they said, know their values, understand their culture, understand their population that they're serving, understand their needs, and how you can specifically help them. How are you and your technology best poised to help them? I would also say that there are, as Donna mentioned, there's about 35, 40, there's a ton of different types of healthcare incubators and accelerator innovation hub programs out there that are very accessible. I've been a part of the Together.Health network for many years now. It's a network of all of these various innovation hubs around the country. Matter is one of them, but they all partner with health systems. Some of them come out of health systems to incubate or provide accelerator programs for startups. I would also say that when you are starting to go through the funding process, you should be finding investors who can help you network. Your investors and your other networks should come with connections. They should come with the understanding that you're going to need a foot in the door at all these various health systems or payer systems, or even Medicaid, agencies all across the country. So be smart about who you're partnering with from the get-go, and think about that before you even enter into contracts with investors. And then I would just say our value guide is a really great resource because it addresses so many considerations that companies need to have answered. And so go through that and be prepared to answer all of those questions, because they're going to ask. They're going to ask all of those questions. And so if you don't have the answer to that, then be prepared to talk about why. And maybe that's a partnership that you want to form. Maybe it's a partnership that a health system is interested in. Maybe they want to get in with earlier stage startups, but be prepared to say, I don't have this yet. Do you want to partner with me in this way?
Thank you. So I thank you very much. I think it has been a great discussion, and I see that we have 40 comments and questions in the chat. So let's turn into our Q&A session, and I kindly asked Usman to look for some of these questions and maybe tell us which one we should address first.
All right.
Is there anything coming on top?
I'm gonna have to go way back.
Yeah.
Okay, let me just quickly pull up a few questions. Okay, so Ben asks, what are the key factors used to select an AI pilot project? So are
And
there
food
any
like-
factors that that will give them an edge, I think, to get picked up for the pilot project?
I'll take a stab at that. Donna
Uh-huh.
will give a much better answer, but I'll start. I'm just being honest, you know, at a big organization, and I guess I think we're a big, or we're at least a medium-sized to big organization. To be honest with you, a lot of where that comes from, you know, we talked a lot about strategy. Clearly, if a startup or comes to us and has, you know, something that sounds like it really aligns with one of those pillars that Donna was mentioning, that's going to get our attention. But in all honesty, where a lot of it comes from is you have a very engaged champion, you know, someone who has an idea and they're enthusiastic about it, and you know that you've got someone in your organization that you can work with that's going to help move things along. And so if I have, you know, for example, if I have an orthopedic surgeon who comes to me and says, hey, Mike, I've seen this, I went to a conference, and, you know, at my professional meeting, you know, there was this vendor that was there, and I was talking to him, and I just started thinking about, wow, this could really change, you know, my practice, and, you know, and they're enthusiastic about it. And then I hear that and I think, yeah, that would probably align pretty well. And they're willing to be engaged and not just say, hey, Mike, I heard about this. Now, will you just take this and add it to your already overflowing plate and just run with it? But I've got a partner, you know, and one of my colleagues who's willing to say, hey, I think I can rally my group and so forth. And we'd really like to do something that's going to have some legs. And so and what I've seen, that's a lot of how these things get started. I don't know, Donna, do you disagree with that, or does that?
Yeah, no, I agree. I dislike the word pilot, mainly because it has different meanings to different people, and sometimes pilots, it seems like they grow legs, and all of a sudden we've gone from pilot to huge implementation, and so there's a little bit of, for me, a little bit of distrust, right, of it. However, you know, I realize here, the reality of it is pilots can be a beautiful thing when they're done well. And Mike is right. If there isn't a champion that really wants to see this through, the good and the bad of it, like I can't have somebody wanting to step in and all of the fun stuff and then step out in kind of the bad, something goes south, right? I need somebody that really is committed. Where I will say, we try to, and Mike brought this up, we're trying to introduce a lot more agile way of thinking. And so the whole concept of agile and kind of, you know, the methodology of Scrum, trying to take things in an MVP kind of way is very beneficial to us. And it's as hard of a cultural shift for my people and the organization here is sometimes for certain partners or vendors that come in, if they don't already have that way of thinking. Luckily, most of you guys in the innovation space already think like that. And you're like, yeah, that's a good, you know, process. And so it's a good way for me to learn from you in that, you know, how do you stand up an MVP and how do you take things that, you know, are quick wins but just need constant little improvements in terms of the overall design of the product or the service that we're trying to do. So that I would add that in. I think that's really important as we look at things and as we iterate, right? I want to be able to do quick sprints of initiatives, and because I know things change way too fast. And if I bring in something and have, you know, project definition and charters and everything, it just, you know, things change so much from the point at which I started to when I implement. I can do it more in a sprint, scrum fashion, I think we're better off. So kind of bringing that mindset really does help.
Great. So Arlen has posted another question. What is the difference between a digital therapeutic and software as a medical device? I think it's for Jessica.
Sure. In most of the world, digital therapeutics fall under the umbrella of software as a medical device. So there's not a separate classification for digital therapeutics. I think South Korea is probably one of the only countries that has a specific category for that. So the US FDA uses software as a medical device, regulatory processes for digital therapeutics.
Thank you.
Great. Okay.
Could I just add one thing to that answer? Thanks for that. I think the confusion is, and I know you're dealing with this, digital health, software as a medical device, digital therapeutics, they all sort of get confused. But the differentiator seems to be clinical validation and FDA regulation. Is that an accurate description? I mean, my understanding is the Digital Therapeutics Alliance is emphasizing FDA clearance, approval, clarification, safety and effectiveness, et cetera, whereas not all AI products, or certainly software as a medical device, demonstrate that. Is that accurate?
Yeah, I would say so. So there is a huge differentiator between various types of digital health technologies, whether it's just a health and wellness product like a fitness tracker, or remote patient monitoring, or clinician decision support, or even virtual care models. And they're different than digital therapeutics. Digital therapeutics treat, manage, or prevent a disease or disorder, and they use clinical endpoints to measure whether or not they're effective, to prove efficacy. So they do go down, they do have risk associated with them, and they go down FDA regulatory pathway. And then depending on their level of risk and what their indications are, will determine what kind of pathway they go through, and also whether or not their prescription required or not.
Thank you for this explanation, Jessica. Usman, any other question that you think we should answer, coming maybe from several people, or something that's important for startups?
For startup point of view, let me check. I think we pretty much answered all. There was one question: what is the minimum data set size that can be used for AI models and applications? So if anyone want to answer that, I don't think there's any specific number, but yeah.
Okay, there was one comment
I have a comment on that. Just I answered the question.
Oh, okay.
Just to give you some context, I actually did a GIM fellowship at Johns Hopkins, and when I was in my fellowship project was on a predictive model, paper-based. So before all this cloud technology and new technology got introduced, and so when the topic of AI came out, people were presenting it as this just novel idea, and it is novel, but what's novel about it is they've incorporated like cloud technology to a lot of existing tools that have been used. And so part of it is to demystify what it is, and then looking at the vendors. I have a couple people that I've networked with in trying to explore an idea. But in general, like my fellowship project was a data set of about 400 people. But in small startups, you have to build your data set. And so the capacity, I think, is important, because when you look at the ways you evaluate it as bias and all these other things that come in. But the goal would be with a startup to start building a database, with maybe a small go of 400. But then with a larger system, if you partner with them, or the applications can be used, the capacity is a lot larger. But the thing to keep in mind is a lot of these AI tools existed as paper-based projects, prior to a lot of the new technology that's being introduced. So,
thank you. Thank you for the explanation. And I think we are kind of getting to an end of the session. So maybe there is one last question from the floor. If anyone who didn't put a question in chat or did, and we didn't notice it, but the question is important, maybe you would just like to ask it. And if not, maybe I will ask the last question. And because there was a comment in the chat that sparked my interest, and this was about the financial sort of robustness of the startup. How do you assess if a startup has enough financial resources to actually survive the pilot or the proof of concept, or to actually partner with you longer term? So is the financial assessment of the startup part of the assessment? Mike, Donna?
Yeah, I mean, I'm looking at that they are financially viable. Usually they have VC funding behind them, and we're applying some good metrics in the background. That's why we kind of leverage the Pivot Center and some of the stuff that we do. I'm not, and we're a state-based organization, I'm not in a position to fund these. Whereas when I was at Ascension would sometimes fund them, but with the idea that then we own your intellectual property. So you got to know what you're getting yourself into with that kind of funding question. You have to come in with a strong balance sheet and where you're at. So Mike, anything to add?
No, I think what you said is exactly right. I mean, obviously we have some financial people here that, if we're starting to get into it, we'll have them take a look and do at least a little bit of an analysis to make sure that the company's got some viability. But I don't have any more insight than that. Sorry.
All right. So any last comments from our esteemed panelists? Jessica, Donna, Mike, what is the last message that you would like to leave us with?
I'll just say before I go, just that I think one of the biggest barriers right now is, or opportunities, is clinician education. And I've seen that come up many times in the chat, but a lot of clinicians don't know very much about emerging technologies in healthcare. And I look forward to clinicians knowing more about the opportunities that are present and how we can start talking more about them and how to use them to best serve their patients in the future. And then that'll elevate all the other discussions and hopefully motivate or incentivize adoption.
Good point. Thank you.
Yeah, I can piggyback on that. And one of the things that's interesting when you talk about AI is you hear about black box, and one of the barriers is actually, that clinicians, not just clinicians, but I think a lot of us, when it comes to AI, it's don't really understand the model very well and how the AI is spitting out recommendations. And so I think that one of the key things is that I would just say is I think there needs to be some transparency and just knowing and making an effort to explain the model in such a way, I mean, not in excruciating detail, but in such a way that the organization, especially the clinicians, can trust it and understand where it came from.
Yeah.
Thank you.
Yeah, I would ditto that. And just, I think the more educated the startups come to the organization, the better off their experience is going to be. So, and just realize, I'm one person, and it's my time can be limited. So I am very careful about, dedicating or kind of partnering. it really has to be worth the organization's, effort. And so you've got to make that argument.
Thank you. All right, so I'd like to thank our panelists for a great session, everybody else who helped to support this session, and all the attendees who made it such a lively discussion. The video from the session will be available for everyone to see from the YouTube channel of the Society of Physician Entrepreneurs. So thank you again, and have a nice rest of your day.
Thanks, everyone.
All right, thank you.
Thank you.
Thank you.
Bye-bye.
Bye.
Cheers.